Well, good morning, ladies and gentlemen. A lot of things has already been said about this topic, so I can, since we are running out of time, I can shorten my presentation significantly. Let's start by some history. History is important in a lot of things, and this guy, more than 50 years ago, already realized that you should not repair thoracoabdominal aortic aneurysms without using adjuncts. I was surprised yesterday to hear that still today some surgeons, mostly vascular surgeons without having experience in cannulation techniques, are still using the cross clamp technique, which is really unbelievable in 2010. But I'm not surprised that they have 22% paraplegia rates in these circumstances. Having said that, you're all familiar with the four types described originally by Crawford, and in which Hazim Safi has added a fifth type. You're all aware also about the numbers of the paraplegia rates, which have been reduced substantially over the last decades. The problem is mainly the spinal cord, and the precise mechanism of the spinal cord injury is still unknown today, because it's probably more than one mechanism that plays a role. Drugs have been tested numerously, but I have only one slide to illustrate that none of them have resulted in a significant reduction of the paraplegia rate based on this technique. Temperature monitoring and hypothermia has been addressed by Robert and Christian more extensively and more scientifically than this slide illustrate, but you should be aware of the fact that cooling the patient, cooling the spinal cord, cooling the brain will increase the tolerance to ischemia. And just to show you this slide, that the best protection, of course, is deep hypothermic circulatory arrest, but this technique is not very often used in thoracoabdominal repair, except in some circumstances, which I'll show you later. Clamping an aneurysm or the aorta has some impact on the brain, on the heart. So it's normal that you should use adjuncts. And initially these were external or internal shunts. These are, at least in my opinion or to my knowledge, no longer used. So the main topic is keeping the equilibrium between the spinal cord perfusion and the drainage of the cerebrospinal fluid and the hypothermia. You know that by clamping the aorta, the pressure below the clamp will decrease and the cerebrospinal fluid pressure will increase. So the basic thing is here to drain spinal cord fluid in that amount that you restore the equilibrium between the perfusion and the ischemia. If you lose a lot of blood, which can happen during this kind of surgery, it may happen that the blood pressure drops to basic levels and that your spinal cord perfusion pressure drops as well. So in order to restore the perfusion of the cord, it really is necessary to drain the spinal fluid because as you're all familiar with the Monroe-Kelly principle, which is a purely neurosurgical principle, within the brain as well as in the spinal canal, there are three components which are embedded in a bony box, namely the neural tissue, blood, and cerebrospinal fluid. If one of these components increases or decreases, it must go similarly with an increase or decrease of the other components, because the volume must stay constant. So what happens during the procedure of a thoracoabdominal repair is that your spinal cord becomes edemous. If we would be able to measure the weight of the patient at the end of the procedure, I'm sure he will increase his weight significantly by adding a lot of fluids, and you see it on the tissues, you see it on the guts if the peritoneum is open, and also the spinal tissue will become edematous, like you see here on this slide. So the only thing that you can do is drain more cerebrospinal fluid to restore the equilibrium. And we know something about it, but for example, the venous component of this thing is something of which we know very little, and Christian has addressed this topic a little bit, but I think it is seriously underscored. There was a time that we used double cerebrospinal fluid drainage because we thought the more we drain, the more we can restore this equilibrium. But we have learned from our own mistakes, and we have had at least 3 serious intracranial bleedings due to a tear of the venous structures within the brain, causing quite lethal intracranial hemorrhages. And these structures are illustrated here. So we still rely on this technique because it's one of the pillars of spinal cord protection. It has some drawbacks, and they are illustrated here, but in at least 2 papers look at the numbers of the spinal cord or the complications related to spinal fluid drainage. It's only 1 to 1.5%. The Houston group as well has illustrated the same results, 1.5% in total complications related to spinal cord fluid drainage, which is neglectable in my eyes. The main adjunct in thoracoabdominal aortic aneurysm surgery is left heart bypass. If you would ask a surgeon if he has only one adjunct and he can choose out of the total number which one he will choose, probably the most important one is the left heart bypass. Simply because it increases the flow and the pressure below your distal clamp, and in that way it restores the perfusion of all the distal organs. This is actually set up. We use a priming volume of about 700 cc's, and only 5,000 units of heparin are added to this priming volume. So we cannot say that we use heparin and the ACT is continuously monitored every 30 minutes and kept at about 200 seconds or lower. It's especially the combination of the left heart bypass or with the cerebrospinal fluid drainage that has enabled us to reduce the spinal cord complications. Left heart bypass has a lot of potential benefits, but also some negative drawbacks. You can cause rhythm problems by your introduction of the cannula into the left heart. You can have bleeding problems. You can have air entered into the systemic circulation. All these things are avoidable. As I said, Hazim Safi and ourselves have shown a benefit of the combination of left heart bypass and spinal fluid drainage. Nowadays, probably 30% of the spinal cord deficits are delayed onset, as Christian has said. It's becoming more and more, or let's say the surgical groups are becoming more and more aware of this problem. And the causes are, again, unclear, but for sure, arterial hypotension is one of the main causes of it, probably in combination with hypoxemia. Very often the patient is extubated a few hours, and then the oxygen saturation drops, the blood pressure drops, he gets rhythm disturbances, and a few hours later he cannot move his legs anymore. So if you have it, you can restore it, and there are numerous case reports that has described the reversal of it by introducing the spinal cord catheters, which is the action number 1 that you should take. But of course you should control the hemoglobin level, you should restore the blood pressure, you should give corticosteroids and other drugs which are written here. Deep hypothermic circulatory arrest has some advantages, but is limited in our center only for distal arch aneurysms or giant aneurysms that preclude a safe entrance into the chest. And of course, if you are unable to ventilate a single right lung, you should go on bypass to deal with the problem. This is done from the left groin, venous and arteriously. It has the drawback that you have to heparinize the patient fully, which will cause pulmonary bleeding for sure. Certainly if you manipulate the left lung, which is unavoidable in these kind of surgery, it will increase the pump run, and for sure it will increase the postoperative the postoperative respiratory complication rate. So I fully agree with Joe Coselli that you should reserve this technique only for special indications like this. So some words about evoked potentials. We have had the pleasure to use it for more than 15 years, not only somatosensory evoked potentials on your left, but also motor evoked potentials. I'm a little bit, I'm not sure if it is helpful in this kind of surgery because it gives false positives and also false negatives. Don't forget that all anesthesiological volatile gases influence the evoked potential. So you really should conversate with your anesthesiologist and have a clear protocol if you use evoked potentials not to be disturbed continuously by false results. Of course, if you have a drop of the amplitude or a decrease of the latency of the motor evoked potentials, it has the benefit that you can do something. You can increase your distal perfusion pressure. You can reimplant major intercostal arteries if they are open or if they are present. I wonder, and this is a question to Christian, if you have a decrease of evoked potentials after having sequentially excluded a segment of the aneurysm, based on the collateral network concept, you should not reimplant them. But if your evoked potentials are gone, should you dare not to reimplant it and oversue it? I think you cannot do it. You should reimplant them. You have seen this slide. This is the old concept. Is it wise to look for the Adamkiewicz? I think it still is, but don't waste too much time and effort for it. But if you have a big intercostal artery between T8 and L2, I think it would be a mistake not to reimplant it. You have heard of it, the collateral network and the spinal cord direct pressure measurement, of which the Mount Sinai group and Christian has elaborated on it. If you don't believe in the Adamkiewicz artery, you should not perform preoperative CT scan or MRI scan to look for the artery, because you can forget all this. We still believe in the reimplantation, and we reimplant it directly because it takes you only 10 minutes. If you do this kind of procedures, it will take you more than 10 minutes because you have to do 2 anastomoses. 2 times 10 is 20 minutes. So I think nobody of us who is performing coronary artery bypass surgery will put an 8 or 6 millimeter tube graft on a coronary of 1.5 millimeters. So the patency of these kind of vessels in my eyes is unknown and certainly unsure. So let me conclude by saying that the protection of the spinal cord in thoracoabdominal aortic aneurysm surgery is a multimodality approach. It's not only the hypothermia, it's not only the sequential clamping,